very rarely in patients whom anticoagulation is contraindicated. Mechanical thromboprophylaxis such as pneumatic compression devices are recommended. In critically ill COVID-19 patients who are in intensive care, since the risk of thrombosis in the lungs are very high, empirical anticoagulation is recommended, even if there is absence of confirmed or suspected VTE. This is because microvascular thrombosis is hypothesized in hypoxemic respiratory failure and confirmed by autopsy studies which show large vessel and microvascular thrombosis associated with VTE. In such situations, low molecular weight heparin is preferred over unfractionated heparin. And the dose of low molecular weight heparin, either a therapeutic intensity, which is 1 milligram per kilogram twice daily of enoxaparin or equivalent, or intermediate intensity anticoagulation, which will be twice daily dose of the prophylactic dose, normally 40 to 60 milligrams of enoxaparin twice daily, or equivalent of other low molecular weight heparin, should be given in the absence of confirmed or suspected VTE. There are many studies looking at the effects of these doses, whether full dose or intermediate dose, on patient outcomes, and results are not yet available at this stage. And patients who are discharged after hospitalization for medical illness due to COVID or at increased risk of VTE for up to 3 months after discharge, and hence post-discharge thromboprophylaxis should be considered. However, the other risk factors such as reduced mobility and bleeding risk has to be weighed for post-discharge thromboprophylaxis, and patients should be educated on the signs and symptoms of VTE, such as swelling of legs, chest pain, cough, hemoptysis, and they should seek urgent medical attention if they develop such symptoms. Arterial thrombosis, as I already discussed, is not as common as venous thrombosis. The incidence of arterial thrombosis in severe and critically ill ICU patients is less than 5%. The most common among the arterial thrombosis are all limb arteries, cerebral arteries, coronary arteries, and superior mesenteric artery, leading to acute limb ischemia, stroke, myocardial infarction, and acute mesenteric ischemia. And the mortality rate of patients who undergo arterial thrombosis is approximately 20%. And now moving on to the next area, which is convalescent plasma. First, I'll talk about convalescent plasma in general, and then go to COVID convalescent plasma. Convalescent plasma is the plasma collected from previously infected individuals and given to the patients to help passive immunity. Convalescent plasma has been used at the time of outbreaks such as polio in the past, and also in pandemics such as Spanish flu 100 years ago. Convalescent plasma was also used in the treatment of rabies, hepatitis B, measles, and Ebola. And more recently, MERS and SARS infection. Convalescent plasma was tried and was found to be safe and confer clinical benefits, including fast viral clearance. And when they are administered early in the disease course, they are found to have clinical benefits. And the COVID-19 convalescent plasma, which is CCP, is obtained from patients who recover from COVID-19 illness, since they develop neutralizing antibodies to various SARS-CoV-2 proteins, and that can happen about 2 to 3 weeks following the infection. Many studies have now reported the use of CCP to treat severely ill COVID-19 patients, and these studies are currently observational and non-randomized. And based on those studies, mortality was lower in patients who received CCP within 3 days of diagnosis of COVID-19, and also in those who received units of CCP with higher IgG levels from the donors. Based on these observations, the FDA has issued an emergency use authorization for COVID-19 convalescent plasma in hospitalized patients. CCP is relatively a safe intervention, and the incidence of severe adverse events is less than 1%. These are mostly due to risks of plasma transfusion, which include allergic reactions, transfusion-associated circulatory overload, and transfusion-associated acute lung injury, otherwise known as TRALI. Plasma donation is based on the principle of centrifugation of whole blood, in which the plasma is the lightest component. So based on this principle, we use whole blood from the donors using a machine called apheresis, and the plasma is separated into a bag, and the remaining blood components are returned back to the donor. For CCP plasma donation, potential donors must have had documented SARS-CoV-2 infection, either an esophageal swab positivity or serological positivity, and should be symptom-free for at least 14 days and meet standard blood donor eligibility requirements. Individuals who themselves were treated with CCP for their own COVID illness are deferred from donating plasma for at least 3 months. Plasma donation can be done as frequently as weekly and for several months following clearance, depending on the antibody titers of the donors. And summarizing my talk and a few take-home points, COVID-19 is a multi-system disease with a significant impact on hematopoietic system and hemostasis. Thromboembolism is a major cause of mortality and morbidity in COVID-19 affected individuals, and higher in patients who are critically ill and in ICU. VTE prophylaxis is recommended in all hospitalized patients. However, empirical anticoagulation with or without evidence of VTE should be given to all ICU patients, and convalescent plasma therapy appears to be promising in critically ill COVID-19 patients. And thank you all for the kind attention, and my sincere thanks to all the frontline workers who are the real life heroes in the fight against COVID-19. Also, thanks to the global scientific community for their tireless efforts in the discovery of safe and effective vaccine and antiviral drugs against SARS-CoV-2. We wish that will happen in the near future, and 2021 will offer better health and happiness to all of us. Thanks again for the kind attention.
Thank you, sir, for your excellent presentation regarding that hematological features as well as their complications and their treatment. And I have one question for you, sir. Is there any therapeutic drug to reduce the cytokine storm?
The cytokine storm, that is what we use, the tocilizumab,
Yeah.
IL-6. That's the only thing which we know, which we use for, that is also only in a severe cytokine storm, and because it has its own side effects and toxicities.
Yeah.
Other than that, there are quite a few cytokine inhibitors being trialed, but not of consistent benefit across the trials. So the current indication is cytokine storm is being treated with dexamethasone, as Dr. Rajendran and previous speakers would have talked about. That's the only thing which has been proven in the studies that is effective as well as safe. The novel agents and antibodies, monoclonal antibodies, have been trialed and not consistently been effective across all the studies. So, and also there is also use of steroids in all the conditions. So, and the studies are also non-randomized. So it's very hard to say that which drug is effective. Tocilizumab is still used in severe cytokine storm, where IL-6 is very high. But apart from that, I'm not aware of any drug which is very effective as well as proven beyond doubt.
And one more question, sir, that hematological features that are seen in COVID-19, as it occurs in all the type of cases or only in severe cases?
Okay, maybe I would have missed a few things because of the technical difficulty. It happens in almost all cases, particularly lymphocytopenia happens more than 80%, where the lymphocyte counts get low because of the virus infection. But what happens is they are more pronounced and more severe in the more severe cases. So when the lymphocyte counts go very low, so then it happens mostly in the most severe cases. But it happens mostly in almost all COVID. I think it's about 96% in most severe ones, about 70 to 80% in non-severe ones for lymphocyte count. Similarly, but other hematological findings like low platelet counts, low neutrophil counts, and then DIC picture with abnormal prothrombin time and APTT happens in lesser percentage, and more so with in severe cases or critically ill patients. So DIC picture is more common in very severe patients with multi-organ failure.
Yeah. Okay, sir. Thank you. Thank you.
Thank you, sir. Thank you so much.
Yeah. So I thank the organizer for giving an excellent topic on COVID-19 and Covidology. I appreciate and congratulate the organizing people of Medicon 20 and 20, and thank you for everything. Thank you.
Thank you, sir, and thanks again for the organizers and Dr. Ramachandran for invitation. And thanks for all the real-life heroes in the world who is doing the excellent job as the frontline workers and the scientific staff also on my behalf. Thank you so much.